The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar, Trauma Verification's March Q&A web conference. Before we get started, I would like to go over a few items so you know how to participate in today's event. For best sound quality, we recommend that you join the audio through the telephone. If you are listening through your computer speaker system, simply open your control panel and select telephone in the audio pane. The dial-in information is then displayed. I would now like to introduce Molly Lozanda, Trauma Verification Program Manager. Welcome, Molly.
Thank you. Hi, everyone. Welcome to March's Q&A. We're going to go ahead and get started. So it's going to be Rachel and myself today going over the webinar presentation. Just going to go over some housekeeping things. Continuing education, to qualify for CE, you must attend at least 15 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar, ending with instructions on how to claim those. If during the webinar presentation you have any questions about anything that is presented today, please email us at cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patient at your trauma center. So with that said, we're going to go ahead and get started. Again, for anyone who's new to our webinar, thank you for joining us. And if you have a copy of the Orange Book handy, please follow along. If you may also download a PDF from the website. And along with this, you must also use the clarification document just to ensure that there's some questions that are a little bit nebulous or standards are nebulous or gray. And then there's also the verification change log. That is where we are housing any changes to the standards. Since the book, there's only one version. I know this comes up quite often. Only one version was printed. So any changes to a standard will be noted in the verification change log, and they can be downloaded from the resources webpage here down below. As I mentioned, clarification verification document and how we update those on a monthly basis and where it can be found on the resources webpage. Just a snapshot of the clarification document. Again, another question has come up recently is our clarification document used to be about 88, 90 pages long. We have now revised that to 44 pages long. And the reason for that is that we deleted, if you will, some of the standards that didn't really have any clarification. They were in the document, but they had like a blank spot. So what we did is we removed that, and we're only going to house this document with those standards that has a clarification. So that is a recent change. And this is just a snapshot of the change log. Again, for any new trauma centers or any centers that are looking to upgrade to a level 2 or a level 1, they can use this document as a gap analysis document, actually, and you can filter it by level and standards and when a change occurred. And just want to point out a new feature that we have. So the recordings of the webinars, you know, they're recorded and they're stored on our website. So what we did just to streamline our web page, because it was a little busy, we have now added a new link. It's in the middle of the web page. It's a webinars web link, and so now we have its own page where all the webinars will be listed with the video or audio recording rather, and the slides. So you can download all the versions of our slides, and again, it'll have all the webinars from past and present time. So I just wanted to point out the new link. All questions are pulled directly from the questions submitted. There have been no edits made to the content. If your question is not answered in today's webinar, the question may require more information and will receive a response from ACS staff within 1 week after the webinar. I also want to say that if there's any questions that I will cover in today's webinar and it was not the intended or the response is not what you thought it would be, or it was a little different, please email us at COTVRC and we'll go ahead and clarify that further. So just a few announcements we're going to go over. The next webinar is scheduled for April 25th, 2018, and the deadline to submit questions are April 13th, 2018, and we're going to go ahead and start at noon Central Standard Time. I know there was a short time frame from the last webinar to this webinar, and that's due to my participation at the STN conference next week, so we just kind of bumped this up a little bit. Just want to go over resources revision process. I know Tammy covered a little bit of it last month during the webinar. Really, it's the same process, or we're still looking for comments to any and all of the chapters, and that public website is still open and it will continue to be open. One thing I will point out is that we are working on Chapter 15, so if there's any comments you have about the registry chapter, you know, whether it's the 500 to 750 number that's in there, or whether it's one registrar, one FTE for, you know, for every 500, 750, or anything regarding PEDS, even within that chapter, please go ahead and submit your comments to that website. And then I just want to let you know that nurses and the work groups are looking at those comments. So very, very beneficial. Just real quick overview of some resources. I do have another tutorial that would be posted in a few days, and I will have a link for you all at the next webinar. And that one is actually part of the series of becoming a verified trauma center and putting together a site visit. So super excited about that one coming through. Again, the Trauma Quality Participant Hub, Trauma Quality Program Participant Hub, just a reminder that that is available to everyone, whether it's a new trauma center or an existing trauma center. If it's a new trauma center, you will be provided login access. And again, it's just a nice area where you can manage your content, your hospital information, hospital name, if there's been a change in a hospital name or staffing changes, or you want to submit data, you want to view your TQIP reports. This is a great area to go ahead and log in and get that information from the account center. If you have any questions about the account center, or you need logins, or there has been transition from a primary, what we're calling the primary contact, which is usually the trauma program manager, you will need to email tquip@facs.org to get new logins. I believe this was brought up last month, so I just want to bring it back up as a reminder. Risk-adjusted benchmarking, CD 15-5, this is a recent change. All trauma centers must use a risk-adjusted benchmarking system to measure performance and outcomes. So this is going into effect August 1st, 2018, where participation in TQIP best meets this requirement. Other risk-adjusted benchmarking programs will be considered and must include the components outlined in the CD 15-5 requirements and rationale document located on the website as you see here. So it's pretty extensive. So if you're looking to do this outside of TQIP, please visit this website and ensure that your program meets that, or the risk-adjusted benchmarking program meets that, and submit that to the TQIP office for review. And please know, and I'm sorry I didn't make a slide for this, if you are a trauma center that is not going to participate in TQIP and is going to do this risk-adjusted benchmarking program, and again, as I mentioned, the requirements and rationale document is pretty extensive. If you are considering doing this or looking to do this at your next site visit, you want to submit this at the time of application. It is going to be a process that will take time, and we want to ensure that the program is successful and meeting these criteria. So again, if you are going to do this, make sure you send this well in advance. We're talking a year in advance for the program, the TQIP team, to go ahead and look at that. So another update that came out of the VRC meeting. So for some of you, we had our Committee on Trauma meeting last week in San Antonio, and this is where the committee meets and we talk about issues that have come up or you know, things that need to be improved or changed. So one of the things that came out of this meeting is that we are making a change to the minimum criteria for full team trauma team activation, CD 5-15. As you know, there are 7 criteria that are required to be part of your highest alert or your highest tier team activation. So one of the changes is number 2, where it reads gunshot wounds to the neck, chest, or abdomen. So we are removing the portion where it reads or extremities proximal to the elbow, knee. That will be removed effectively immediately. So if you're a trauma center that did not have this in your criteria, no worries. You don't have to put it in there. For any trauma centers that revise their criteria to include this, you know, we have now made this change, so you can keep it in there. There's no harm in keeping it in there, but if you decide to remove it, that's also acceptable. If there were any trauma centers that underwent a review and were cited for not having this, please contact us immediately. We will definitely address that and fix that as part of the outcome process. So again, just want to mention that that was removed. So we're going to go ahead and move on to scheduling reminders, and I'm going to hand this over to Rachel.
Thank you, Molly. Good afternoon, everyone. We could jump right into the first slide, site visit application. The application, as usual, must be received in our office at least 13 to 14 months in advance of the requested site visit dates and before your center's expiration date. And basically, this time will hold your spot and, in addition, provide centers plenty of time to prepare and complete the online PRQ. Currently, we are accepting applications for December 2018 and all of 2019. Just a side note, though, we still have some openings for July, August, and September. So if you are a center who right now maybe your time frame is in the fall, if you desire to have your site visit in July, August, or September, please reach out to me, give me a call, and so we can make this happen, okay? And this next slide is basically a reminder to please let us know if there is any changes, any staffing changes. We know you send in your application 13 to 14 months in advance, and we understand that there can be staffing changes. So if your TMD, your TPM, your administrator changes, please feel free to, or please let us know, actually. And also another way, as Molly had mentioned, the Trauma Quality Program Participant Hub is also a great way to make those changes. And because it could become a challenge if we don't get these updates when we're sending out final letters and reports or confirmation emails. We definitely want to make sure that we are getting it to the correct person. And also what would be beneficial or helpful is on the site visit applications, if you can note the credentials, for example, MD, RN, EMT, NP, PA, you know, so we can address everyone properly. Let's see, regarding the OTL form, for new trauma centers that have not gone through our process, you will be required to submit with the site visit application an OTL form. And this is required for Level 1 trauma centers, Level 1 pediatric trauma centers, Level 1 adult, and Level 2 pediatric trauma centers. And you could find this form on our website at that link listed on the slide there. And now for those trauma centers that have previously completed an OTL form and they're going on to their next visit. If you've had no change in the OTL, then you're not required to submit another form. So again, those who have had a change or are new to the process must complete and submit an OTL form with the site visit application. Another item that we need to know when scheduling, when you're turning in your application is if you are going to, if a surgeon at your center needs an alternate pathway. And the alternate pathway, this is for surgeons who are trained overseas. So basically, if a surgeon was trained in the US or Canada, this doesn't apply to them. But if you have a surgeon that is foreign trained, we ask at the time that you are submitting your site visit application that you would make note of it on the application, as well as send in a copy of their curriculum vitae. And this information we ask for during the time you're submitting your application, because this could also be a process. We have to submit this information to a subcommittee, and they determine the eligibility of your surgeon to go through the alternate pathway. And if your surgeon is eligible to go through, then the next step would be is to have the on-site evaluation by a member of the same specialty. So, and then for those surgeons who have been previously approved by the alternate pathway, they're not required at the next visit to have a review by the specialist. But however, they are required to meet the alternate pathway criteria. Okay, so for the pre-review questionnaire online access, so once your application has been received, the VRC office will provide you with an email receipt, and this usually comes from Anita Johnson. This will confirm that we've received your application. And in that same email, the logins to the online PRQ will be provided. Again, we also ask that you do not submit payment with the application. You'll receive an invoice about 60 to 90 days prior to the scheduled visit. And then your center will be billed annually for the trauma quality program fee. And you could also see the fee structure on our website at the link listed on the slide below. So scheduling site visits. As mentioned in the last month, we have a new scheduling process that has been implemented. Visits are now being scheduled quarterly. Right now, we are scheduling for third quarter visits in 2018. So that's July, August, and September. And the difference for the scheduling process is that centers are now being asked to provide us with the exact dates that you would like to have your visit. So most likely this date that you provide us will be the dates of your site visits. And this basically cuts down a lot of the back and forth because once the review team has been secured, you'll receive a confirmation email which will list your reviewers and their complete contact information. And with this new process, they've typically are able to be scheduled 120 days prior to scheduled visits. Site visit preparation with reviewers. The ACS travel agent will arrange the site reviewers' flights, and basically they'll make these travel plans approximately 20 to 30 days prior to the site visit, and the hospital is responsible for arranging and paying for the site reviewers' hotel accommodations as well as ground transportation. So we ask the trauma program managers to reach out to the reviewers directly within 30 days of the site visit, basically for their flight itinerary and just to get any logistical information such as the hotel confirmation, pick up and drop off from the airport. So we just want to make sure that your visit is a positive and successful experience.
Thank you, Rachel.
You're welcome.
So we're going to go ahead and move on to general questions. So a question from the PRQ. We recently completed our first level 2 pediatric site visit. Now we are scheduled for our level 2 adult verification visit in December. So we omit all pediatric questions on the upcoming PRQ. So because they were just verified or at the Pediatric Trauma Center, you can omit, or actually, if the portion of the review will focus on the adult review for the patient type, you want to make sure you're selecting adult only, not adult and children. So again, make sure you select adult only. What would happen is it's going to ensure that no pediatric questions are displayed. So basically, pediatric surgery will not be displayed when you go onto the online PRQ. Patient admission policy: can a level 3 hospital define minor injury patients, skin, tears, etc., admitted to medicine as excluded from trauma registry? And then there was a second question to that. Is there an ACS definition on an admission with inclusion-exclusion criteria? So this has been said over time that the ACS, we, the VRC, do not set the admission policy for trauma centers. You as an individual institution will set that criteria. So if you do not want to admit or capture these patients, that's totally up to your policy. So each trauma center will set its own admission and registry entry policies. Trauma center volume and verification levels. How much weight is given to trauma center accreditation level by the annual volume of trauma patients? A trauma center has level 2 accreditation. Can they be awarded level 3 on the site visit without having applied for that level? Can a trauma center apply for both level 2 and 3 at the same time and take whichever they are approved for? So several questions in this, and the way that I answer this is, let me clarify that level 2 and level 3 do not have volume requirements. So that doesn't really weigh into whether a trauma center is verified or not verified, since there's no criteria around that. A trauma center cannot apply for multiple levels at the time of the visit. So basically, if you apply for a 2 and a 3 and decide to have both visits, it just does not work that way. If you have them a year apart, it's very possible to do that. But if you are considering to do that, please reach out to me so we can discuss some other opportunities for your trauma center. If a trauma center requests a site visit as a higher level or at a higher level, say, I don't know, a level 1, and it's determined that the center does not meet all their criteria or requirements, you may ask the reviewers to add a note for consideration to be verified as a level 2. True that this will be the same if it was a level 2 trauma center being surveyed and they don't meet the standards, you can drop to a level 2, level 3. So it can work either way. Or you can have the trauma medical director submit a written request to the VRC office. What you should not do is change the PRQ. If you're going to change levels, you need to contact the VRC office. The PRQ is programmed internally to reflect only those questions that pertain to your level. So by making that change yourself, it's going to impact on how that report's going to turn out. So I will say the type of visit and the level of the visit cannot be changed during an on-site visit. I know some trauma centers have tried to do this. It just cannot be done. In addition, as I mentioned, the PRQ should not be changed if the type or level changes. If it does, please contact us and we'll go ahead and fix that for you and provide you a new PRQ. Tips, I had a question about audit filters. Is there a published list of recommended ACS audit filters for trauma registry, PI? There is in Chapter 16, and please know that this is not an inclusive list. You can add whatever filters you want to capture and track. So in Chapter 16, in the resources manual on page 119 through 127, there are some filters built in or that you want to capture. As I mentioned, you may also add additional audit filters that you want to track and monitor. So that can really range from anything that you want to track, like times to OR, or any delays to the OR, or, you know, physician tracking response times. Again, anything you want to track, but there is a list on in Chapter 16 that describes some audit filters. PIPS loop closure, we had a couple of questions about how do reviewers like to see loop closure demonstrated. Is there a specific PI process format that the reviewers prefer? Both great questions. So ideally what you want to do when you are going to demonstrate loop closure, you want to have the PI or the PIPS record attached to the chart, or have it flagged to direct the reviewers to the electronic PI record. This again will vary among trauma centers. Everybody has it set up a little differently, but one of the things you want to ensure is that if you are currently setting up for a site visit, make sure that you have had a conversation with the lead reviewer and how your program is set up regarding PI process. So what reviewers want to do ideally when they're looking for PIPs, or what they're looking when they're looking through your cases, is they're gonna they want to see how the problem was identified. Was it through routine auditing? Was it by a report that you run? Was it a patient complaint? Was it a surgeon complaint? They just want to know the details of how that came about. What did the initial investigation consist of? Again, how did that come about, and what detailed information came along with that? Who was that reported to? Did you report it to your leadership? Did you report it to a trauma medical director, to your nurse manager? And what were the recommendations that came out of it? And were there any corrective actions? Was it discussed? If it was discussed, what was the corrective action? And how was that closed? What impact did that cause? So you want to make sure that you have all those details in your PI process. If there was an issue identified, if there was no issue identified, you can just simply put on there that, reviewed, discussed, no issues identified. Along those lines, what some reviewers would like to see, and again, this varies among reviewers, as many of you know who've undergone a review. Some recommend having a spreadsheet that have could have columns titled corrective action plan, responsible person, and evidence of loop closure. You can use anything along these lines to kind of have that summarized for the reviewer. So anything to make that PI process easily accessible to the reviewers and easy to follow and easy to read would be ideal. Trauma flow sheet revisions. Are there any plans to create or revise any nursing documentation within the new book, especially on trauma flow sheets? This is a great question. I know there's been a lot of talk about the trauma flow sheet and how some of them are dated and need to be updated, and whether they're useful or can be done electronically. So at this time, there have been no discussions on any of the nursing documentation, and that's only because, as I mentioned before, we've started with Chapter 6, or we finished with Chapter 6, or completed Chapter 6 rather, and we are still going through the revision process. So at any point in time, you can certainly submit your recommendations or consideration through the stakeholder website to take for us to consider documentation or the flow sheet. As maybe Tammy had talked about, but I've also mentioned that in our revision work groups, we have STN nurse partners that will look at all these feedback. So they definitely will be looking at the content and ensuring that, documentation and possibly the flow sheet is taken into consideration when revising that chapter. Transfers. Our health system has a single call transfer center for all 3 hospital campuses. When our request for transfer is made to the call center, for example, a same level fall with an isolated hip injury is required to be admitted to the trauma center, or is it allowable to be accepted at an orthopedic hospital in the same health system, same geographical region? This is going to depend on your hospital or trauma center's admitting policy. So if the policy calls for these patients, the single falls or hip fractures or hip injuries, to be admitted to the trauma center, then the transfer center should be directing that transport to that trauma center. So again, that's going to be dependent on your admitting policy and what's best for the patient. Transfers and volume. Transfers by EMS, air need to be included in NTDS data. Do they count toward trauma center volume numbers even if not admitted? So this has been our rule for verification. I want to clarify that. I know there are some distinct differences in how we define interfacility transfers and length of stays and what's admitted into the registry. Again, what is admitted to your registry is it's a hospital policy. So at no point in time will we tell you not to add something to your registry. What we can recommend, what should be entered for verification purposes, that is. So this is our statement for verification. If length of stay is less than 23 hours and the patient was not admitted to the trauma service, this would not be counted in the volume numbers. So for completing the PRQ, the volume is based on the number of trauma patients admitted to a surgical service, that being your trauma service, orthopedic service, neurosurgery. So again, this is for verification. It's a little different for NTDS. So we're going to go ahead and move on to CD-related questions. Again, question about admission volume. During February webinar, you mentioned 23 hours length of stay rule to count as admitted. NTDS does not have a length of stay rule. Can discrepancy be addressed so ACS, VRC, and NTDS are in agreement? I so truly agree with this. We are working on aligning our definitions. As I mentioned in the previous slide, we are aware that there are some distinct differences in how what we're calling an admission possibly, as well as an interfacility transfer. I know those two keep coming up over time, so we are definitely working, or I should say VRC and NTDS are working to align our definitions during the revision process. So please keep that in mind and stay tuned. Question, can you please clarify or define CD2-7 and give some examples that would meet this criteria? So what I did is I just cut and pasted what CD2-7 reads, and this really is about the 15-minute response time for the trauma surgeon. So the presence of such a resident or attending emergency physician may allow the attending surgeon to take trauma call outside the hospital. In this case, local criteria and a TIPS program must be established to define conditions requiring the attending surgeon's immediate hospital presence. So again, this is talking about the response times for the 15-minute highest level of activation. And what this really translates to is the trauma center must have established and defined criteria for when the trauma attending is required to be present within 15 minutes for the highest level of activation. The highest level of activation must include the minimum criteria noted on page 38 of the resources manual, and I've also inserted a slide in the following slide, with additional criteria based on the trauma center's demographics. So, quick snapshot. So again, minimum full trauma team activation criteria is you have to have the minimum 7, as you see here. We call it minimum 6 in the book, but it's really 7 with the ED discretion. As I previously mentioned, we're omitting or removing or deleting the lower extremities proximal to the elbow and knee, so that's going to go away. But as a trauma center, you may also add additional anatomic and mechanism of injury. You can have different sections to this. And again, these are just some examples. This is nothing, it's not written in stone. You can modify this as you see, but the 7 minimum have to be part of your activation criteria. So as you see here, you can add suspected pelvic fracture, you can have an open or depressed skull fracture. Mechanism of injury can be ejection from a vehicle, telemetry data consistent with high-risk injury. So you can add as much as you want or as little as you want, as long as the 7 minimum are part of your activation criteria. Transfers, more questions regarding transfer patients from a physician's office being a transfer. More details, please. I realize there are differences between NTDS and verification program, as I mentioned. However, for verification purposes, and again, this should not impact your NTDS data collection, but when you are completing the online PRQ, we are asking just for the verification aspect of it. Those centers that are undergoing a consultation or re-verification or verification visit for the first time, and you're completing the PRQ, the way the VRC defines this is patients who are transferred in or out to from another facility, whether that is through a sister hospital or within the same campus, freestanding ED, or what you may refer to as a satellite ED, or a private physician's office. Those are considered interfacility transfers when it comes to filling out the PRQ. Again, that should not hinder how you're capturing that data for the NTDS, but definitely a little different for verification purposes. Limited tier trauma team criteria. Is there a maximum amount of time the trauma surgeon has to see limited tier trauma patients that are admitted? So again, this is one of those areas where the limited tier depends on your hospital policy. You're going to set the criteria for the limited tier and establish a response time for when the attending surgeon is required to respond to the patient at bedside. Again, this must be monitored through your PIPS process to ensure there are no delays. In addition, you want to continuously review and update the criteria based on the PI triage outcomes. I'm sorry, I think I'm losing my voice through this webinar. Limited tier response by PAs. The question is, can an ED PA act as the primary provider for trauma patients? For the limited tier, the PA may be the primary responder as long as the hospital has credentialed them to do so. They must be credentialed in ATLS. That's a requirement. With this said, the limited tier criteria protocols must clearly speak to this, meaning there has to be some guidelines in the policy that talks about the PA being able and credentialed to respond. And in addition, have language for the type of injuries and time expectation for when the trauma surgeon is expected to respond. All must be monitored through the PIPS process to ensure there are no delays. Ortho patients and many light trauma patients, cracked rib, minor lacerations, go to medicine and admit. Is a consult from ortho or general surgery okay? If the patient met trauma inclusion criteria and was admitted to medicine with an orthopedic consult, that is acceptable. Just another question about non-surgical admissions. What is the ACS definition on non-surgical with regard to non-surgical admission? So these are patients that meet trauma inclusion criteria and are non-operative. They may be kept by the trauma service for 24 hours and transfer care to the hospital's medicine or family physician. So for example, I provided a really quick snapshot of an example of non-surgical. For example, this is a 43-year-old that fell from a 10-foot ladder, had a small subdural, external abrasions, and is diabetic. So again, I just kind of broke it down by 4. So clear by AEM, admitted to medicine. You kind of want to avoid that, but if it happens, you want to make sure you're reviewing that through your PIPS process. Cleared by trauma and ED, admitted to medicine or the hospital is for neurosurgery consult, that's better, and that's totally acceptable, as I mentioned. Patient was admitted to trauma with neurosurgical consult, that's really good, or that's the best option, or admitted to trauma, as I mentioned, 24 hours with tertiary exam, acceptable, transfer to family physician with neurosurgery on consult. Again, that's also a really good option. Pediatric critical care, Peds Surgical Critical Care Board certified or eligible. Are you required to have 2 or 2 between critical care and surgical? Defined board eligibility is at 10 years. If they don't take boards, are they no longer considered eligible? I know a lot of questions in this one. Hopefully, I can answer all those questions in one slide. In a level 1 pediatric trauma center, regarding this requirement, CD 10-17, it is 2 board certified or board eligible VE/VC surgeons with additional certification in medical or surgical care. So the board eligibility period that we all talk about varies by specialty. So trauma surgery has 10 years. I think emergency medicine may have between 7 and 10 years. And then it does differ between neurosurgery and orthopedic. So if we're taking pediatric boards and we're saying it's 10 years, again, I don't know what it is. If it's 10 years, we're going to go with that. And the provider did not take their boards within that time frame, but was granted an extension for reasons that they presented to the board, and the board extends their board period, if you will. They will have to provide a letter from the boards that attest to that, and they have to send that to the DRC office or present it to the reviewers at the time of site visit. If the provider was not granted an extension just because they just exceeded the time frame or exceeded the number of exams they were allotted, then technically they're no longer board eligible. So that definitely is an issue, and that would be cited as a deficiency. Backup surgeons and pediatric CME. Question is, are general surgeons in a level 1 combined center required to have 4 hours of CME annually if are backup for peds trauma at night? So there are no requirements for the adult surgeons who are covering for the pediatric service. So basically the requirement is if they're the first responders and they're managing the trauma patients, pediatric or adult, they're required to meet the CME. However, there is a component to pediatric CME, which is 12 hours over the course of 3 years. So it's 4 hours every year. So we're not asking the adult service to do that. Regarding CD10, CD1110, and CD1111, does taking trauma call mean the anesthesiologist on call team or any caring for trauma patients? So I just want to clarify, and I think the question comes in the resources manual, when it talks about the anesthesiologist, it says anesthesiologist taking call. The word trauma is not in the book. So the way I'm reading this is the word trauma was added in error to the submitted question. The statement in the manual refers to an anesthesiologist who is taking trauma call. So it does mean trauma call. So that also means that they're caring for the trauma patients. Level 2 trauma centers. An operating room must be adequately staffed and available within 15 minutes at a level 1 and 2. There were multiple questions in this slide, so I split it between 2 slides. The first one is, what is considered an adequately staffed operating room, and what team members make up a complete OR team? We don't have criteria for that. The composition of the operating room team will vary by institution. And again, this may include, but it is not limited to the following. This is just a suggestion. It could be the operating room nurse, the scrub nurse, surgical tech, surgeon, the anesthesiologist, the CRNA. And again, you can expand on this list or you can shorten this list, but definitely you need the anesthesiologist and the surgeon. Again, we don't have any criteria on what composition the staffing should be. The second part of that question is, it also says operating room must be available. Please clarify what this means. Does this mean having an available room, open OR suite, or staff that has all the necessary equipment ready to go? I provided some examples here of what that may look like. So there's many ways to demonstrate immediate, 15 minutes is immediate, availability for an operating room. And again, this can be done with having designated trauma rooms or an OR suite, staggering your start times in the morning, direct to OR with unstable patients that bypasses the ER, demonstration that there are enough operating rooms during various times throughout the day so that an emergency procedure can bump a case. Again, that's where staggering comes in. So if you're doing any of these processes, there needs to be policies and procedures in place that assure this process is needed when needed. What do you use as a DOA definition? Is it so this has come up quite often. We, verification committee, along with NTDS, do not define DOAs. So I've only addressed it for verification, so we do not have a definition for what is a DOA. DOA and what we're calling a DOA, or what you as an institution will call a DOA, will be defined by your trauma center. So that would be part of your admitting policy or inclusion criteria, really. Do cage aid requirements include pediatric patients? What age is considered not acceptable? I don't know if the question here was asking if I knew if the cage aid includes pediatric patients, or if it can include pediatric patients. And I'm sorry if I'm not answering the question, and if I don't, please reach out to me. I'm not sure if the cage aid includes pediatric patients. I took a quick glance of what that looks like, and it looks like it could be include pediatric patients, but I'm not really sure if it does. The age for alcohol screening for pediatric patients will be defined by each individual institution. Typically, we see the age of 12 as a standard, but again, that's not in the Orange Book. It's not written as a criteria, but again, that's going to differ by each individual institution. If the 80% of injured patients must be screened for ETOH, substance use, applied to all patients in registry or just activations. I know we've covered this several times. Again, if you're new to our webinar, past webinars do have this question, and it's the same. The answer is the same. It is acceptable to applicable to patients regardless of activated or non-activated. I know everyone thinks it's just for activated patients, but it's for all patients, regardless if they were activated or not, who meet inclusion criteria with a hospital stay of greater than 24 hours, who are admitted to the hospital and are entered into the registry. So that's what we're looking for the 80% threshold for. CME, in a previous web conference, it was stated that visiting speakers conducting grand rounds or speaking at a symposium unaffiliated with the host trauma center would not count towards external CME. However, page 136, 137 of the Orange Book states programs given by visiting professors or invited speakers are considered external CME. Can you clarify as to why there's a difference? And I thought this was a great question, because there is a slight difference to this, and this person is right. It does say that in the book, but I think the piece that's not in the book, that's missing from the book rather, is that if you are having invited speakers or a visiting professor give a talk at your trauma center, whether that be from the same hospital or even from an external hospital, if the center applied for CCME credit and it was granted, then obviously you can definitely use that as external trauma CME. What happens in most cases is that the trauma center does not apply for ACCME, then it would be more of an internal process and not an external, because ACCME is external. So again, if the center was approved by the ACCME to grant external CME for the invited speaker and or visiting professor, that is acceptable, and we would need documentation to verify that, and usually it's either by way of a certificate or a transcript. When calculating physician CME, is the reporting cycle the same as the survey reporting year, or is it at the end of the last survey period? That's how I'm reading this. CME collection is based on a 3-year cycle, typically starting from the time of the last visit, essentially the last month, not the last day, but you can go up to the last month, up to the time of the upcoming visit or ending with the reporting year. So it's 3-year cycle, the last month, so you can either collect CME leading up to the site visit or when your reporting year ends, and the difference is that there's a 2-month lag. So if you have physicians that are short on CMEs, they can use a 2-month lag to catch up on some CMEs. Are there CEU requirements for CRNAs, and what is the difference between internal, external CME for physicians? CRNAs are not required to obtain CEUs. External CMEs are approved by the ACCME and obtained through attending national or regional conferences or by way of an online course. These are usually, they usually have certificates that they can get following these conferences and the online course. Internal CMEs are usually provided internally by the institution. What we've seen over time is that usually the hospital would grant their physicians and providers of 1 hour of internal CME for attending M&M meetings. Again, that's not set in stone. That will vary by institutions. Liaisons and non-liaisons, please review who needs CME for orthopedic, neurosurgeons, anesthesia. So I have a couple of questions on this, so I just put them in this one slide. Same question, similar question rather, about 16 hours yearly or 48 hours. Orange Book has yes, clarification only lists the ortho liaison. If yes, is it same for neurosurgeon emergency medicine? So I want to clarify the anesthesia and radiology panel members are not required to have CME. Liaisons for ortho, neuro, emergency medicine are required to obtain 48 hours of external trauma-related CME over the course of 3 years. This may be done by obtaining 16 hours of CME each year, or if they want to do it all in 1 year, that's also acceptable, but it's nice to have it spread out over the course of 3 years leading up to a site visit. For non-liaisons, same would be true. However, in their case, for the non-liaisons, which are the other panel members and who take trauma call, they can do a combination of either external trauma-related CME or internal CME, as I mentioned before, or through an internal education process. So again, they can do a combination of all of that. It's basically what's easiest for you to track as a trauma center and what they can provide. If you do an internal education process, just make sure you have a process of what that mechanism looks like at your trauma center. Self-assessment, many of our orthopedic surgeons complete ortho self-assessments for CME. If they're a guideline, they can use for how many hours to give. And then there's another question about, can physicians use self-assessment examinations for trauma CME? The only self-assessment I'm familiar with is CSAP and also for board preparation. I don't know if that's what this question was alluding to. So again, the information that's here, it's the understanding I'm going to use. That if the self-assessment for preparing for the board certification, the maximum number of CME the provider can apply toward the CME requirement for both either preparing for their board certification or taking their board certification is 33 hours within 3 years for the verification period. So again, if that's not the question, please reach out to me and I'll go ahead and address that. Pediatric surgeon and ICU, do all pediatric surgeons still need to require CMEs if they are not seeing pediatric patients during the initial resuscitation phase? What is the CME requirement for PICU attendings in-house 24/7 for level 1s that only treat patients younger than 14 years of age? Well, the answer is they all need CME. If the pediatric surgeon and or PICU attendings manage and or provide care to the pediatric patients, regardless of age, whether they're in-house or they're not part of the first phase, but they're managing those patients, they are required to meet the CME requirements as noted in CDs 10-39 and 10-40. And that concludes our webinar today. I want to thank you for participating in our webinar.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's March Q&A web conference. If you have any other questions, please contact cotvrc@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today and have a great rest of your day.